Alright, good afternoon guys, my name is Nurul and this is my groupmate Aurora, and today we'll be presenting on a patient with multiple myeloma. So the patient in our case is a 42-year-old male by the name of Max Manley, handsome guy here, and he has a concern that his urine turns white whenever he urinates and hits the hot steel pylons, and he feels fatigued easily and has bone aching. Unfortunately, he slipped down the ladder and fractured his femur. As you can see, femur is actually a thigh bone. It's the longest and the strongest bone of the skeletal. And being strongest, having a fracture is something that is very sus, very weird, you know. And then he has anemic upon admission, and he is unusually pale and weak. So, multiple myeloma is basically a cancer of the white blood cells. White blood cells comprises of granulocytes, monocytes, and leukocytes. And leukocytes has T leukocytes and B leukocytes. And plasma cells is a type of B lymphocytes, which is the immune cells that specialize in secreting the antibodies. And antibodies is AKA immunoglobulin. So we use between both of them. It's basically the same. So plasma cells resides in the bone marrow, which is a soft spongy tissue that is in most of the bones. And therefore multiple myeloma is the cancer of the plasma cells, where there is a tumor formation and also overproduction of plasma cells in the bone marrow. And these cancer cells can multiply excessively and produce enormous amount of specific immunoglobulin, and this is called monoclonal gammopathy. Monoclonal means one type of antibody, and gamma means gamma globulin, and pathy is pathologies. So there is production of one antibodies, and because of that, there is because the cancer cells multiply and expand in bone marrow, so it damages the bone marrow, and because of that, it disrupts the production of normal healthy blood cells and disrupt the production of normal functional immunoglobulins. So you can see here, this is the normal patient. So there is polyclonal antibodies, which means there's a lot of different types of antibodies for different sites of epitope sites. But for multiple myeloma, there's a lot of monoclonal antibodies, which is one type of antibodies, which only fits one type of epitope site, so a lot of it is basically useless. Multiple myeloma has abnormal features, which is usually remembered as CRAB. So you can see here, C for calcium. Hypercalcemia is basically high levels of calcium. R for renal failure, basically the kidney function is insufficient, can cause renal failure, kidney failure. A for anemia, low hemoglobin, which means it's low amount of oxygenated red blood cells. That's why he's feeling anemic, looking pale and weak. And B for bone lesions, which is osteolytic lesions. Osteolytics means the breakdown of the bones, which causes the bone pain, which is the first sign of multiple myeloma. And because of the bone pain, there's also an increased risk of fracture, which result in the femur fracture. Now these are the medical laboratory tests that we have done alongside with Miss Jacinta, and then going on with Aurora.
So one of the laboratories we did was the serum protein electrophoresis, which is one of the most commonly ordered tests when we suspect the multiple myeloma. It's also used as a screening when we want to identify the monoclonal bands. So we run the serum protein electrophoresis is based on the electrical in the charge of the proteins. So we can see that a normal smear of serum proteins will be the albumin, the alpha, beta, and the gamma globulins that include all the immunoglobulins. So in our case, a max percent monoclonal bands in the gamma zone that we can infer that are globulins. For further tests done, we will know which immunoglobulin is the one that is elevated. So we also know the albumin. The albumin is a protein synthesized by the liver and is one of the major proteins in the serum. It has a molecular weight of 67 kilodaltons, and we use spectrophotometry assay to determine it in the lab using the bromocresol green. We first did a control that fall into the range. So, and then we run the match sample, which it has a concentration that is low according to a healthy individual. It has a 25.24 grams per liter. So this decrease of albumin is due for the body trying to compensate the high levels of globulins. So we also run the hemoglobin levels. So we did as well as spectrometry assay with the cyanomethemoglobin method. We also run the control, which fall in the control range, and match sample is also below, indicating that it has anemia. The anemia in multiple myeloma is usually normocytic and normochromic. It indicates that the red cells have a normal color and a normal size of the cells. So have the differential of leukocytes were normal. We also have this test, the erythrocyte sedimentation rate, which measure the rate in which the cells rails fall in the bottom of in a sample of whole blood, fall in the bottom of the tube. In this case, we have an example of the wintergreen tube. So we measure the distance in an hour when the sediment of the cells, we measure the distance of the red cells fall in an hour. In the case of Max has a very elevated ERS compared with an adult, normal adult, which is the 1 to 10 milliliters per hour. This is due because the changes of proteins in the serum alter the set potential of the red cells, making the red cells to stick together. This also causes the formation of the Rulles formation, that is the stick together of the red cells. It's important to mention that the erythrocyte sedimentation is not the same as the hematocrit, even though they have a similar appearance, because this is the rate in which the cells fall in an hour, but the hematocrit is the ratio of the cells in the whole blood by centrifugation. So we also determine use the urine stick with our paper plastic segments that can detect different particles in urine. In this case, for us, it's important to detect protein in urine to see if there is any kind of proteinuria. So in maths, it was negative because there is no albuminuria in maths sample. And the digestive can just detect albumin, but cannot detect Benson-Jones proteins. It's not sensible for these kind of proteins. So what is the Benson-Jones proteins? Benson-Jones proteins are the monoclonal free kappa lambda light chain found in urine. That is come from the antibodies, that the light chain of the antibodies. That can be detected through electrophoresis technique, including the immunofixation electrophoresis that we're going to talk later. As we said, it cannot be detected in the digestive app. It's a very important characteristic of the Benson-Jones is that precipitate in a temperature of 40 to 30 degrees and then redissolve in 100 degrees. Because the high amount of light change produced in the body that are deposited in the distal tubule of the kidney, producing an impaired function, producing an impaired renal function. So this is the normal function of the kidney. It's excretory, regulatory, and endocrine. Because the excretory function and regulatory function will be affected due to the light chains proteins deposited in the distal tube of the kidney. One of the tests that can we run to determine the function, the renal function, are the creatinine, the urea, and the glomerular filtration rate. As well as we want to know the prognosis of the patient, we can use the beta-2 microglobulin, which is a component of the major histocompatibility complex class 1 that are present in all nucleated cells. This is used as a tumor marker, but it's not specific for multiple myeloma. It can be found in different diseases like lymphoma, chronic lymphocytic leukemia, also renal dysfunction, and some infections. So that it is just an indication and used as a prognostic test. So we can say, like, in which stage of the multiple myeloma Matt is in stage 2, because he falls in the criteria that is his levels of beta-2 microglobulin is 4 micrograms per liter. Is in stage 1 is when it's less, below to 3.5. The stage 3 is when it's about 5.5, and max doesn't follow in those ones, so we can say that max is in stage 2 of the disease.
Okay, so from the serum protein electrophoresis, we know that there's a thick band in immunoglobulin, and from there on, we need to know and determine the antibody isotopes. So we did immunofixation electrophoresis, which is the more sensitive method to detect small monoclonal antibodies and light chains. And there are 5 different types of heavy chains and 2 types of light chains. And for us, we found out that there is IgG and kappa light chains. So for the radial immunodiffusion, it's exactly a method to quantify the amount of antigen concentration. So what we did is we will have the gel which has the antibody, and we pipette in the antigen, and the antigen will disperse until it reaches a zone of equivalence where there is the number of antigen and the number of antibodies is the same. So the lower amount of antigen concentration is smaller circle, and higher amount is bigger circle. And then we will take a ruler, take the diameter, square it, and then we will put it under the graph against the antigen standards of high, medium, and low. However, our RID result were unusable because it doesn't fall within the reference range of 6,500 to 16,000 milligram per liters. Our result is 14,500 milligram per liters. Theoretically, because Max has higher IgG, so he should have higher than 16,000. And the reason for error is the incorrect value of medium antigen standards, and the control value is too high and not in the range, therefore it's unreliable method. So in this case, as you can see in the graph, that the control is away from the range, which is the yellow and the light blue, and Max is in the range, which is wrong. So the calcium level, we test 4 different samples, the honest water, standard, control, and Max. We use calcium reagent, which is quantitative, and we use the formula, and the control is within the range, so it's reliable, can be used. We do Max sample, which is 322, which is above the healthy adult individual, so he has high level of calcium or hypercalcemia, and the reason for that is because he has excess bone resorption, where there is destruction of the bone tissues by osteoblasts and excessive release of the calcium. Because in bone matrix there's a reservoir of minerals such as calcium and phosphate. When there's a breakdown of the bone, it releases excessive calcium and phosphate. That's why both of them goes up. So overall, the serum protein electrophoresis will show a thick band of the immunoglobulin. So there's a low levels because it compensates the high level of immunoglobulin, and then there's a low level of hemoglobin. IFE shows IgG and kappa light chain. RID shows it's supposed to be theoretically high concentration. Calcium phosphate is high, and he has Langerhans protein, and because of there's a lot of changes, it affects his renal function, and then what? And then there's a renal insufficiency, sorry, and then because of that there's renal failure, and we can check for the renal based on 3 different methods: creatine level, pumps, as well as GBR that Aurora have just said. So overall, because he has high level of immunoglobulin of 1 antibodies, so the rest of the other antibodies is low, therefore he is susceptible to infections, and then is susceptible to infections, especially bacterial infections such as the pyogenic infections, which are pus forming infections. Examples of it is pneumonia. And then reference. Okay.
Thank you. Guys, questions?
Sorry guys, last time I had pneumonia as well, so my lungs are really affected.
That's good.
You're absolutely right. Well done.
Thank you.
Well done.
Any questions?
No questions?
Questions, guys?
Big bonus marks if you ask good questions.
Just a question. You may have touched on this, I know I just sort of zoned out, but you did say that the urine dipsticks will detect protein, but they can't detect Bence-Jones, so you have to run a different way to detect the Bence-Jones proteins. Why can't you detect the Bence-Jones proteins in urine?
Okay, so in the urine dipsticks, it can only detect high molecular weight. So for example, is the albumin. Albumin has high molecular weight, and Bence-Jones protein has small molecular weight. So it is sensitive to albumin, but it's less sensitive to globulins and insensitive to light chains basically. So because of that, urine dipsticks doesn't get it.
So you very briefly touched on the end there that people can become susceptible to infection, not making enough immunoglobulins. Are there, particularly bacterial or pyogenic, but are there specific infections that these people are susceptible to that you know of?
More of those pus-forming
They say they're
infections.
pyogenic infections,
Yeah.
but like cellulite or...
Yeah, yes. And using them as well.
So a quick question from me. In your serum protein electrophoresis, how do you detect the protein?
So we detect the protein using. Oh, sorry.
We detect the protein based on the charge of the, it's what you can detect the charge of the protein. So we put the control, that is the first.
No, the charge is important for how it modulates, but how do you see the protein? What are you detecting it with?
So what we did is that.
We are staying
Yeah, with what?
with the blue.
Someone else can help?
Sorry.
That's a blue stain.
Blue comestin. Blue comestin stain.
Yeah, okay, that's good, thank you.
It wasn't commercial actually. This is a question. It just says acid blue saying.
Yeah.
Acid blue.
I'm not going to ask you how.
Just one question perhaps on the metabolism of the bone lesion. So you briefly mentioned that.
Yeah.
Elaborate a little more what happens in the bone? What are the stomach lesions? Who's responsible for that?
What's responsible?
What's responsible?
No.
Osteoblasts.
Yeah, so osteolytic lesions, there's a breakdown of breakdown
The
of the
breakdown of
bones.
the bones, and the osteoblasts will be That's what is being lost, like the destruction of the cells. So that is why they increase the calcium and the phosphate on this.
Thank you.
Very good. Excellent. Give you some feedback.
Good job, very good job, thank you. I quite liked everything really. I think just in general, maybe a little less information would have prevented the speaking really, really fast. Like we were trying to cram it into the 50 minutes. I think technically you were on time, I don't know, but you was,
A little over.
oh, look, I got by a few seconds. But like,
We must have to decide
what to keep in there. That's all right. I mean, if you practice a couple more times, maybe seeing what could have not been in there anyway. But slides were great. I thought they were very clear, and the flow was great. I think that you could have just said before you got started. Yes, this is Max. Yes, we know he has multiple myeloma, so we're just going to give you a bit of a background, and then the test that we ran to come to that conclusion kind of thing, just so we're kind of clear that we know what it is, instead of just jumping into the background. Apart from that, I thought you guys were great. It's a great effort to remember what you were saying. I think you know pretty much everything. You can ask you questions and pretty much answer them. So it was very good on my part to be able to just speak to your slides. Yeah.
And we would like to take this opportunity to thank Ms. Jessica McDonald for guiding us and the guys team in case study too.
So yes, congratulations. I think, and also given a group of 2 people presenting is a little more effort than for other people that have larger groups. So you did a very, very good job. I enjoy very much the way you manage your slides, the size and the distribution. That was very good. I like your explanation of the immunology, of course, the freshman, so that's very good. There's a couple of details that could have improved your slides. You included the calculations or your data. You don't really need that in a presentation like that, so you could have saved some space there and had a little less information there on the slide. But overall, I thought the slides were very, very well designed, easy to follow and easy to read. There was in the slide of the immunoglobulins, I didn't understand exactly the labeling of in the bands. You had the immunoglobulins at the top. That didn't come across clearly what you meant. You were shifted, and that's like could have been a little better. But overall, I thought that you presented very well. You interacted with the audience very well. You engaged. You combined the 2 of you and sort of made it interesting. And overall, I thought the presentation was very good. A very good clinical presentation too. The way you presented the case was succinct and sufficient and clear. That was very good.
Yeah, second motion, I thought it was good. I like the way you both presented to the audience and took the slides. That was really good. You obviously done quite a lot of practice to make sure that you understood what you were talking about, and I thought that was great. So really thank you for that. A couple of your slides had a little bit too much information, I think, as well as just moving them around a little bit. And I thought it would be good if you could cite where you got the pictures from in a couple of cases that was missing. But other than that, I really enjoyed the presentation. So really, really well done, and you handled the questions well as well. So good job.
Did you guys have references through your slides as well as at the end? As one of us that thing?
Citations on the slide.
Okay. Just make sure for when you are referencing images or text that hasn't come, from your own knowledge, that you do put your text reference on the slide as well as putting them at the end, just so we know what piece of information has come from what source. But yeah, same deal. You guys presented really well. You have wonderful, clear speaking voices. You have all the content. You answered all the questions. A couple of the answers were a bit crammed into the end, but you know your stuff really well. You were able to answer questions wonderfully. So good work.
Very well done. We have next is case study 3. So